Good morning, everyone, and welcome to the October meeting of the Healthcare Services Review Project Committee. And I'd like to get the meeting called to order at 8:30 a.m. And with that, I'd like to hand it over to Kristen to do the roll call. Kristen.
Supervisor Canepa.
Here.
Jay Wilverding.
Here.
Brandy Hopkins. Here. Jennifer Vanstein. Here. Ed Kiernan.
Here.
Queenie Macedo. Here. Jeff Wolkamp. Not present. Greg Diederich.
Here.
Rick Castro.
Here.
Abe Nunez.
Here.
Chris Zuniga.
Here.
And Stephen Ding is unable to join us today.
Thank you. Item number 3 on the agenda is approving the minutes from September 20th, our last monthly meeting. Does anyone have any questions or comments regarding the minutes from last month?
Second.
Kristen, can you take a roll call, please?
So you have a motion from Rick Castro, second from Supervisor Canepa. All those in favor?
Aye.
Thank you.
I'll
I'll
abstain.
abstain.
I'll abstain as also. I listed on the phone, but I wasn't here.
Okay, thank you. Okay, moving on to our information and discussion items. Item number 4 is presenting the August 2023 financial results for our county clinics is Chris Zuniga. Chris?
Good morning, everyone. Okay, we begin our fiscal discussion with a usual slide pertaining to our managed care Medi-Cal population. We've enjoyed an upward trend for the last 3+ years, and we're now starting to see the effects of Medi-Cal redetermination, which, as we explained last month, is the process by which Medi-Cal sort of enrolls its beneficiaries, or the beneficiaries enroll with Medi-Cal. In July, we saw a little bit of a downtick, and we saw an uptick in August. But we have budgeted for just about a 20% reduction, and so we expect to see that as the fiscal year continues. In terms of visit volumes, we came in at 12,936 billable visits for the month. The chart we are looking at represents 36 months of billable visits for the FQHC. And as we noted last month, the single largest piece of our financial class is that Medi-Cal managed care piece, coming in at 76%. Versus budget, we were under budget by about 34 visits. So we just about met budget. But on the year, we had a poor performance in July, so we're still behind on the year. Okay, so our P&L for the month. Those roughly 13,000 visits resulted in $2 million in net patient service revenue, which was just about in line with budget. On the revenue side, the most interesting piece or point of highlight would be our grant revenue. And we came up well short of budget, as we did in July. We have an unfavorable variance to budget of $334,000 for the month, and an unfavorable variance of just under $700,000 for the year. So that's really where we're focusing our efforts. We've met with our grant teams. They understand the requirements to recognize expenditures and then therefore recognize the associated revenues. Happy to report, at least for the month of September, because we have our September financials done, that there is an uptick, a significant uptick in September of about $800,000 in grant revenue, but we'll explain that next month. But that's really the biggest piece of the revenue picture that we should focus on. 340B also came in under budget. We've had issues with our IT team and the submission of data to the network pharmacies and our contracts, but we're working through that. So again, we expect upticks there too. On the expenditure side, any questions there, folks? No?
Yeah, Chris, I have one question on the grant revenue, because
Yes, sir.
obviously I noticed the same thing when I reviewed the financials. So you mentioned, and you can see it, it's mainly in the 1 month. Is that something structural that is occurring here, that we may see more of that, or is there something more, what do I want to say, isolated to that period or month that created an anomaly?
No, I wouldn't call this an anomaly. I would say that our grant revenues team enjoyed a great period of grant performance, mainly due to one very large grant, a federal grant last fiscal year, called the ARP grant, and that was $5 million over 2 years. So our grant teams had a large focus on that, and we did great. We ended fiscal year 23 great with grant revenues. I would also say that, you know, just the realities of our political situation and what we've been sort of living through as an organization took folks away from the focus in doing their jobs. And that's just a pragmatic view. But yeah, we remain vigilant. We are meeting with our teams. There is no issue in terms of knowing what to do. We know what to do. We have to have our grants management team perform.
Okay,
That's it.
all right,
And
thank you.
Jay, I'd also add, I think the budget revenue was budgeted straight line, and some of these grants are kind of tail-ended, and if, as you mentioned, can't recognize the revenue till we make some benchmarks, but I think that also means there might not be offsetting expenses, so a net bottom line, but I think some of these will pick up later on in the year as we start rolling, and some of these grants are you submit the grant, you get 50%, you do a performance or an update, you get others, so some of the grants are atypical type
Okay,
grants.
all right, thank you, guys.
Yes. And as we'll see when we talk about the balance sheet as well, we still have 1.7 in deferred grant revenue sitting on the balance sheet waiting to be recognized. So moving towards the expenditure side of things, salaries and benefits essentially came in as expected. Professional fees came in a little higher than expected. We do employ a lot of contractors, and we also saw our Vasquez auditor fees come through, along with some contracted services associated with grants that are accounting for the budget variance of $61,000 there. Another larger variance would be the dues and subscriptions. We had sort of an early termination of a particular software, and we had some early termination fees, and so they're hitting in the month of August. Some other items, but that was the bulk of that $62,000 variance. All told, you know, we came in at $4 million, which is what we expected to come in at. There's a net loss, unfortunately, $300,000. Unfavorable net income or net loss variance of $473,000. On the year, we're at a loss of $443,000 against a budgeted $382,000. So we're under budget by over $800,000 from a profitability standpoint. And so we're meeting with our teams. We want to really meet our benchmarks for visits, billable visits. And again, that grants piece is pretty significant.
Chris, just one question on the expense side, and maybe I didn't understand what you were saying a bit ago. On the salaries and wages, there's an unfavorable variance of $185,000 for the August, and then almost $300,000 year to date. I guess similar question to the grant. Is that a structural thing, or is that something we may see diminish over time?
The July salary, certainly every year, we took a look at the last 3 years in the month of July, and I guess it's the beginning of the fiscal year. A lot of physicians sort of are front loaded with their PTO, and that hits our expenses and stuff. But then we also, in August, I think we have Dr. Fadu's payout, not necessarily Alice's, but Dr. Fadu's hitting the books.
Oh, I forgot about that. Okay, thanks.
Going to skip over the next two slides, folks. You're more than welcome to read more additional detail regarding our revenues and expenditures or variances of greater than or less than 10%. But we're moving to our balance sheet. Cash and cash equivalents really didn't move. Actually, the total assets side of the equation didn't really move too much. Other liabilities, moving to the liabilities section, other liabilities did see an uptick associated with the accrual of payroll liabilities. And as we mentioned earlier, we have 3.8 roughly in deferred revenue. A lot of that is going to come off. About $2 million of that is going to come off when we see the final audited trial balance or final audited results for fiscal 23. However, 1.8 million of that is deferred grant revenue. So we, again, need to do what we can as an organization to recognize those funds. Total assets are 37.1. Total liabilities are 10.5. Total net assets are 26.5 million. Total liabilities and net assets are 37.1. All right, as we did last month, we moved to cash collections, and we see a chart of 36 months of cash collections represented by date of service. And we have seen an upward movement of the trend line from the gray to the blue. We continue to see that in August. In August, we're looking at 1.9 million for dates of service of August. You see how that compares against the previous August of 1.8 and then 2 Augusts ago at 1.6. The single largest piece of our cash collections is Medi-Cal in totality, making up over 94% of our cash collections. And when we compare the billable visits against the cash collections, you can see that there's a positive correlation, as anyone would expect. So, just the movement from the gray line to the blue line, the trend lines moving upward in the graphs means business done, and we'd love to see even more upward movement on there. Any questions here, folks? No. All right. Moving right along, again, as we explained last month, the fiscal 24 HRSA metrics become more robust as we continue through the year. But as the sort of calculations are working out at the moment, the cost per unique visit sits at $572 for the fiscal year with 2 periods in it. And the medical cost per visit is $331 per medical visit.
Could you explain that
Yes.
for me, Chris? I'm not understanding, and it looks like a big drop. We trended going up in cost, and now we're less than half, and I just don't understand how this is calculated.
That's okay. That's a great question. So over the course of a fiscal year, we will see approximately 31,000 to 32,000 unique patients in the year. Now that will translate to about 140,000 billable visits, but those are the unique patient numbers, and that would go in the denominator of this statistic.
Okay.
Year to date, we're about 14,000 unique patients of that 31,000. So we're seeing the unique patient count, right? We only count it once per fiscal year. The unique patient count is sort of front-loaded, so the denominator's large, and then our expenses sort of tack onto that, which we don't have enough expenses
grows
yet
over
to
the
make this a meaningful statistic yet.
Got it. I got it now.
So the bottom statistic at 331 would be our medical cost per medical visit. The top statistic is per unique patient, so the denominators are different. So if we talk about the whole fiscal year, you could think about the medical visit or bottom statistic having a denominator of about 140,000, whereas the unique patient statistic will have a denominator of about 31,000. Yeah, so our PPS rates are well below $331. They do not cover this.
So let me see if I can explain the top number back. So what happens is, as people come in the start of the fiscal year, they're counted as one because they're unique. And then as they come back again and again, they're still one on the denominator, but the costs flow into the numerator, making it bigger and bigger because we're accumulating those when we're not accumulating the visit once they've walked in the door.
Perfectly said.
Awesome. Thank you.
Okay, folks, these are our industry benchmarks, and we go to our comparisons versus our industry benchmarks. The first sort of column there is the targets themselves at 3% for both operating margin and bottom line margin. Our days cash on hand target is greater than 45 days. Net patient receivables, according to Capital Link, is desired at less than 60 days, And then total labor cost inclusive of all purchased services or contracted services is less than 70% of total operating revenues. The next three columns are the 2021 national median for these figures, the 2021 California median for these figures, and then our unaudited results for 23. And you can see, again, as pointed out last month, that our audited results are very similar to both the California median and the national median. However, fiscal year 24 is not working out that way. We are definitely not profitable to the tune of -6%, both operating and bottom line. Our days cash on hand are healthy at 167 days. And then our labor costs, as a result of our reduced revenue and not meeting those grant sort of milestones or revenue numbers, our labor cost as a percentage of operating revenue sits at 88% for the moment in the fiscal year. Any questions? I'll address them now.
I don't have any questions other than the ones I already asked.
Thank you, committee. Appreciate the time.
Thank you, Chris. Appreciate the presentation. And with that, we're going to move on to item number 5. Abe Nunes will be presenting the August financials for San Joaquin General Hospital. He's going to need the clicker. And I want to make one editorial comment on this. This is probably the best, most informative set of financial statements I've seen come out of the hospital in the 10+ years I've been with the county. So I wanted to acknowledge that up front and let you know how much I appreciate that. So thank you.
Don't do that, it's gonna come back.
No, no.
Need more money.
Yeah.
Do not do it.
No, credit to the accounting and finance teams over at the hospital.
Yeah.
They're doing a big effort to get us caught up.
Not you.
No. Okay, so we're 2 months into our new fiscal year, still very early. I would say that from a margin perspective, our financial results are hovering around where we expected them at the beginning of the year. You can see that we booked a loss for $1.2 million versus a budgeted loss of $1 million. So we're unfavorable by roughly $200,000, largely due to unfavorable expenses. And we'll go over the budget variance by expense category here shortly. When we look at our financial results from a cash flow viewpoint, we're actually positive by about $270,000. So that's primarily due to the timing of placing some of our assets in operation, but we'll go over the depreciation expense here shortly as well. Overall, when we look at our key volume metrics, looking at the whole house, so looking at adjusted patient days, which is our inpatient days plus our outpatient equivalent days, we're slightly over budget by a little under 1%, and that's what's driving the positive variance in net patient revenues. When we look at our inpatient specific volume metrics, it's kind of a mixed bag. When you look at our adult patients, so looking at our patient days and our discharges, we're about 3% short of target. On the positive side, our deliveries are trending very strong relative to prior year and budget. Looking at the case mix index or the complexity of the patients that we're treating this year relative to target and prior year, we can continue to see an increase in that metric, which is great to see. The CMI for Medicare of 2.01, that's more indicative of a level 2 trauma facility. A big reason for that improved coding is due to the launch of our CDI program. So we're starting to see the higher revenues associated with that.
And just to make sure, Supervisor, that you understand what the CMI represents, it's really making sure that, so patient for patient, and the best example I can give you is a pneumonia patient. Typically, pneumonia patients are a result of something else, typically an infection in another part of the body. In the past, we were coding them as a pneumonia patient. In current, we're coding them as a septic patient because they meet that criteria based on their things. And the difference in reimbursement for pneumonia is about $6,000. For sepsis is about $20,000. So every decimal point on that CMI that we increase represents tens of thousands of dollars. So that's why that focus, one of the common spirit focus part of the MSA was making sure that we bill correctly. When I came here and I looked at the statistics, it looked like we were a general acute care hospital like any other community hospital. And once I walked into the ER, we realized the disconnect. That focus on making sure that we code properly has been tremendously important to us. And those results are very, very hard to achieve, and we're very proud of that. So just to make sure you understood it.
So the 0.12% increase is huge.
It's huge.
Absolutely.
Yeah.
Absolutely. A few more volume metrics. When we look at our surgeries, 8.5% over target, definitely trending in the right direction for us. Our clinic visits turned around. We were under budget in the first month of the fiscal year, but we picked back up here in the month of August. Our ED visits are short of budget and have contracted year over year by about 10%. I'm hopeful that's seasonal. Generally, when we approach the winter flu season, we do see a spike in our ED visits. So I'll need to take a look at how we spread those volumes here in the next month or so. And then looking at our length of stay, we're trending favorable to target slightly at 5.1. I know that our case management team, is doing a diligent job in trying to place our patients as soon as they're discharged by our providers. Overall, when we look at operating revenues, we're at about $1.5 million or 2% favorable to budget, largely due to the stronger outpatient volumes and our deliveries, which are trending favorably. Our supplemental payments are lower than budget since we're taking a more conservative approach in recognizing some of these revenues due to the fact that our quality metrics are not where we need them to be. But I know that there's a lot of effort. Thank you, Greg, for pushing those quality metrics to improve. Looking at expenses, we're about $1.5 million or 2% over budget. Looking at our overall cost structure, normalized for acuity, so total cost per CMI adjusted discharge. Due to the increase in CMI, we're actually favorable to where we ended up last year. And our purchase services are also lower than budget, which is impacting that metric favorably. Salaries and benefits are favorable to target due to the fact that we still have a high number of vacant positions, which we're obviously actively looking to fill. But our travelers, that continues to be the biggest opportunity when you look at our expenses. In this year's budget, we did increase our budgeted cost for travelers, budget over budget, but not to the level of our run rate. So here's just a snapshot of our income statement. We'll go over the more granular version here shortly. But overall, when we look at net income for the month of August, kind of towards the bottom in bold, we booked a loss for $500,000 versus a budgeted loss for $500,000 on budget. From a year-to-date viewpoint, you could see our net loss is $1.2 million, as mentioned, versus a target of $1 million loss. So we're unfavorable by $200,000. And then here's the more detailed version of our income statement. So this is year-to-date through the first 2 months. Revenues overall trending favorably by about a little under 3%, as are the net patient revenues. One item of note, when we break out our revenue variance between service, so breaking out inpatient versus outpatient, because of the lower number of discharges, our inpatient revenues are actually lower, whereas our outpatient revenues are favorable because of the increase in outpatient surgeries. Generally, when your surgeries pick up, that impacts all your ancillary services, so your imaging, lab, therapy services. I bring that up because for San Joaquin General, there's a considerable difference in the collections rate between inpatient and outpatient. On average, when you look at our blended collections rate for all payers, for inpatient, we get reimbursed roughly 15 cents on every dollar that we bill out, versus outpatient, it's hovering around 7 to 8%. The driver for that variance is our payer contracts with the commercial payers for trauma services. We get reimbursed a very favorable rate for trauma. So when those inpatient volumes, in particular trauma cases, dip, it could impact the overall collections rate that you see on the income statement.
So the outpatient revenue really represents true Medi-Cal revenue. That's why you see the 9 cents on the dollar. You would see the same thing on the inpatient side, because that's the bulk of our, let's just say, population, with the exception of trauma. And trauma is where we do see the commercial payers, because that they come to us automatically from a large area. And so because of those, and I'm only telling you this to help us all understand the importance of that trauma service. Number one, it's an amazing service, but number two, it's the one place where we're actually getting revenue that we can provide a margin for. So it's really critical that we continue that process going forward. And just to give you, I think I shared this statistic yesterday. My last hospital, we saw about 70 to 75 traumas a month, same level 2 trauma center. We saw 22 traumas in a 12-hour period. Here at San Joaquin General, 22 in a 12-hour period. And it's just, it's an unbelievable statistic in a community this size, and I think it's just because of the vast area that our trauma services cover. But a real important part to us and something we do really well.
So Rick, quick question along those lines. So I can understand why you'd have commercial payers coming in through the emergency department because of, somebody gets in a wreck on I-5 or 205 or whatever, that's where they're gonna wind up going. And then their insurance is whatever their insurance is, where somebody who walks in saying they don't feel good, typically would go there because they're on Medi-Cal. Do you have any idea or sense of the percentage of commercial payers that come in through the emergency department, just in general? And what's that in relation to the overall patient mix? I'm just curious. I don't know if it's a statistic you track.
Yeah, we can certainly pull that, Jay. I mean, our overall, when you look at our payer mix, 80% is government, right? So Medi-Cal is about 65, we
Right.
include managed care, 15% Medicare. Commercials hovering around 15%. This is for all services.
Right.
And then the other 5% is self-pay. But specifically to the ED, I mean, we could certainly pull.
I'll bet that jumps up dramatically.
I think what people do when they look at an emergency room, and is they want to get in, they want to get out. If you're not talking about a major issue, if you're talking about, a UTI in the middle of the night or something like that.
Yeah.
So the one challenge that all of us have, because our main competition is Joe's and Dameron,
Right.
is the ER visits everywhere take forever, 3, 4, 5 hours. And so I think that our focus is, we have in our budget and we're working on it, we have a overflow room. Because what's happening to the hospital is we don't have enough beds in the hospital. So oftentimes, and it could be up to 20, and we have 24 ER beds. So we could be holding 20 inpatients in our emergency room and trying to serve the public with 4. So we're trying to get those out so we can flow the ER, because we know that's a business line that we'd like to grow because of the fact that it's not going to be standard Medi-Cal. And don't misunderstand that we are privileged to take care of that population, and we're trying to do it in a better way. But they do pay 8 cents on the dollar.
Wow.
And Abe, did we have a pickup? Because I know 4 or 5 months ago we worked, Health Plan of San Joaquin was not paying trauma activation fees because they were relying on a stale EMS policy. That has unwound now?
Correct. We did correct the trauma billing criteria, so we're in sync now.
But we didn't get the back pay, right? We didn't receive.
We went back a year.
We went back a year, okay.
So I have a question. So those 2 numbers there, the professional fees, do those, and the utilities, do those even out there? I mean, or you're gonna have to change
Yeah,
it in
the
budget?
professional fees that's where we book the expense connected with our travelers. So right now we have over 100 vacant positions. So it's the high dollar registered nurses to backfill for all the open positions that we have.
Okay, so then how do you have vacancy rate savings, so then where does that come in? So you're
So-
saving money
so
by
you-
not having that position?
Correct. So there's a savings under the salaries and benefits line. The savings, so if you look at the very first expense line, you could see we're lower than budget by a little under 2%. That favorable variance would be higher. Reason it's not is because we had to pay out the employee retention credit this year, which increased our actual salaries. Otherwise, you would see a bigger offset to the professional fees under the salaries and benefits line.
Oh, so the traveler's in the second line, not the
Yeah,
first line.
correct.
Okay.
And that's
And
the
then
big,
and then
that's
the
the
utilities, why the utilities?
Yeah, so utilities, I think it has to do with the way we spread the budget. Generally, you see higher utilities in the summer months with electricity. And full disclosure, there was an accrual that was missed at last fiscal year end for about half of that unfavorable variance in the utilities. So we had to book the expense this fiscal year where we should have at the end of last
So
fiscal
it's
year.
only 30% theoretically.
Yeah, correct.
Okay.
And then, yeah, we'll take a look and apply more seasonality in terms of how we spread our utilities expense in our budget. Because as mentioned, usually you see higher electricity during the summer months, but.
But
we straighten
that
it.
push for travelers is
Yeah.
the biggest push we have. That's the scenario when you look at it. We have, you're really paying almost 2-to-1, 3-to-1 for the salary of the traveler versus our own staff. And so we'd like to see our salaries at budget and our professional fees go down significantly, but it's really, it's the biggest challenge we have.
And that's why the number's so different, because it's such a big number on the wages.
Correct. Yeah, obviously that's our biggest opportunity when we look at our income statement.
Rick, I have a question, or maybe Abe is better to answer. On the purchase services, you have a $1.7 million favorable variance. Is there any potential that there'd be between purchase services and professional fees, there was any coding?
We are reviewing some of the coding of some of those costs,
Yeah.
Jay, but a lot of that has to do on the favorable variance in purchase services. We did bake in some expense associated with revenue cycle initiatives. Some of these are in the early stages, so as we progress through the year, we will see a lower budget variance.
Okay. All right, thanks.
The 3M coding project, for example, comes, is something that we expect we'll be implementing in the second quarter of this fiscal year, so that will drive up the purchase services actual expense.
Got it. Thank you.
And Abe, speaking of salaries and benefits, I don't think SB 525 was just signed. That doesn't impact you until June or July at the earliest, or maybe not till 25?
Correct. So initially, the minimum salary requirement for public hospitals is $18 versus private hospitals is $25. So potentially that could lead to more employee turnover in that, there's a 20% gap between what we're paying here at a public hospital versus a St. Joe's. So something to consider here.
I don't think that, I think that bill affects us significantly in a negative way. And it's not because we kind of avoid the cost. We are, as a public hospital, given latitude to be much lower than the privates. But we're struggling in those departments already. We have, first time in my life, we were using travelers sometimes to fill dietary and EVS positions. So that gap is going to become bigger because the private hospitals, for example, Joe's will go to the 25. So an EVS person can come to San Joaquin at 18 or go to St. Joe's at 25, or, Dameron's going to be under the same scenario, although I think financially Joe's is already there where Dameron's not, and Dameron's struggling financially anyway. So I think that bill is going to have a significant effect on them and the capacity in the county. That's the only reason I bring it up. But for us, I see it kind of as a negative because we just fall further behind and become more challenged with filling those positions.
Okay.
And here's our balance sheet. So comparing the month of August to where we ended last year, we're currently under audit for our last fiscal year. We'll report back on how that engagement progresses. But overall, when you look at cash year over year, we have dipped by about $11 million. Some of that has to do with an increase, or two-thirds, I would say, it has to do with an increase in our accounts receivable. I know with the health plan of San Joaquin, there was a change in their system in terms of how they process our claims. That issue has been resolved. We had to rebill all those claims for about a 2-month period, so we expect our cash collections to pick up here over the next couple of months.
It's interesting you bring that up because you can see I've got those 3 lines highlighted. Is I would have expected with your revenue focus, those would be inverse, and you would see cash go up and receivables go down with an accelerated cash collection and a billing throughput.
Yeah, absolutely, and that's definitely our objective. Is just that this health plan being our largest payer, impacted our cash through the first 2 months, And also, the way we manage the accounting for our supplemental payments.
Okay.
We have to put in intergovernment transfers, which impacts our cash line, then we won't get the payments until, in subsequent periods.
Which is hitting the third line there, right?
Correct. And then also, we did see a decrease in our accounts payable year over year, our accrued liability, so that also impacted our cash line.
Got it. Thank you.
And this one, so here's our finance dashboard, kind of an eye test. Green is good. When we look at the column furthest to the right, that just evaluates both our key volume metrics and our profitability, our financial ratios towards the bottom versus target. I think we pretty much went over most of these in our first couple of slides. So here's some key volume graphs specific to our inpatient services. When you look at our patient days and discharges, two graphs at the top, you can see our days are down and our discharges are relatively level to budget, but we have contracted year over year, so that's something to keep an eye on. Since again, when we look at our inpatient business, that collections rate overall for those services is higher than outpatient. When we look at the chart, bottom left, average length of stay, good trend so far. We're favorable to budget and prior year, and with more complex patients, right? So that's a good correlation. We're seeing sicker patients, yet we're discharging them sooner. So I know case management has a lot of initiatives there around placement. And when we look at the chart at the bottom right, deliveries, good story so far through the first 2 months. Here's some additional volume graphs. Surgeries trending in the right direction at the top. You can see our trauma cases are about 1% lower than targets, but relatively flat. And then our ED visits, we expect those to pick up as we approach the flu season. Here's a couple of graphs around our billing operations. When you look at our cash collections through the first 2 months, to your point, Jay, we want to see an increase higher than 2%. That system issue with the health plan impacted the numbers in the first couple of months. I know in September our numbers did come down as well in cash. One thing that is critical for us to drive these initiatives is to have a time and attendance policy in place. Just last Friday, I think we had 8 people in our billing office call in sick.
Ooh.
26 nurses.
Yeah, so
Payday Friday, 26 nurses. It's not. It's insane, right? We have no sick policy, and our sick policy is at 20+% a month. And I say that because we have no ability to hold people accountable. And if you think about that 20%, it's all replaced with higher paid labor, overtime, special pay, all that. And it is demoralizing to the staff. It is unacceptable for a healthcare professional. And for the life of me, I don't understand how a hospital can not do 2 things. We don't have an attendance policy, and we don't have the ability to flex.
The ability to what?
Flex our staff.
Okay.
So when our NICU sits at 4 patients, and it varies from time to time, there's nothing I can do to stop all 8 nurses from coming in. That means we have 2 nurses for every NICU baby. And I say that so passionately because that is so far from the industry norm that it's hard to imagine. But I don't understand from a county perspective how it doesn't affect the county as well in regards to percentage of are we normal in our absentee rate? It's not normal in the hospital, not normal by any stretch in the hospital. Are we normal in the county as a whole?
I would probably say no. I don't have anything other than anecdotal evidence to support that. And we don't have nurses anywhere, you probably have them in your healthcare, So maybe the good question would be to Greg, do you have the similar anomaly, and if so, how do you manage that?
So I don't think we have anything rising to that level, but I would say that we do have attendance policies, and people that are abusing that system, we put them on, basically, they provide a doctor's note if it reoccurs or if they've used a substantial amount.
We work in a hospital. We work in a hospital. So to get a doctor's note is like, hey, Joe. You know, again, I'm just being blunt. I'm not.
Yeah, no.
I'm not complaining. I'm trying to affect change.
Yeah,
And so for us, we need a robust, and the one that we sent most recently is when you have 3 absences in a 3-month period, you start down the line, right? What are you doing differently? What are we going to do to change this behavior? And if it was consistent, you know, you could also understand in a hospital when the flu starts, our employees get sick as well. But that argument goes right out the door when you see that the days are higher on the weekend, no question, and they're higher on payroll Friday than any day. So maybe we should just stop paying people. I don't know.
what's that?
So you want a note from the medical examiner? Is that what you?
So I bring this up because I think that we presented I think we gave, most recently to HR, we gave the cottage policy.
Yeah.
Cottage Health. Cottage Health is a, you know, very successful group of people. They, I actually did a white coat with the CEO way back when I did my MBA, and the guy was just smiling. He said, everything here's paid for. We got Oprah. We got, you know, we got a foundation that you can't believe. But that's the policy that we presented to HR trying to get us started with.
Okay, so let's do this, we'll take this off, we're going a little kind of off the grid here, although it's relevant, because it spills into your numbers and we get it. But why don't you and I get together and we can work with our HR director and even Brandy and brainstorm, because I have a few thoughts.
Good.
And,
Yeah.
and I
Yeah.
could share those.
Yeah, thank you for that, because obviously a lot of initiatives to lift both the quality and the financial results of the
Yeah.
hospital, but we need workers, right? We need workers to show
Understood.
up.
Hey, I have one question too, I meant to ask when we were on the key volume graphs.
Yeah.
I had asked the prior administration about having this kind of data, and you know, you gotta measure what you've got going on in order to be able to manage it, right? Are you getting this information? Obviously, it's coming out of your system, one of the 2 systems you're working with, right?
Yeah, correct, from the accounting and finance team and our revenue cycle folks
Okay.
as well. So from Cerner, that's our patient accounting system.
Right.
And then our ledger system is PeopleSoft.
Okay, so you are able to carve that information out?
Correct.
We're getting it to be
It's a-
a more functional system.
Correct.
And it is, you know, it is our system, so we have to work through it, but yeah. it's good.
That's very encouraging and impressive.
Yeah.
Like I said, I had hammered on the table when I was auditor about, how do you not have this information? And now to see it is.
A lot of it is manual, Jay, to be honest.
Yeah.
Not as our system setup is not as robust as other facilities, but, you know, the team is doing
Okay.
a diligent job.
Well, that you can get it at all is
Yeah,
very
right.
encouraging.
Yeah.
Thanks.
So we talked about the case mix index, or the complexity of the patients, of our inpatients. Trend is favorable. You could see that year over year, we're seeing a higher metric, which indicates that, you know, the quality of our coding has improved, which is going to translate to higher reimbursements.
And you see that blue line that's low, that's what we talked about. That's kind of the basic healthcare of a hospital typically. So the blue line represents a lot more of the labor and delivery patients that come in, you know, here for 2 days, usually no complications. So just to give you an idea of what those lines mean.
Okay, so just one more slide here quickly. So when you look at our overall cost structure, so looking at our cost per overall volume indicator normalized for acuity, you can see that last year we ended at roughly $15,005 per CMI adjusted discharge. And year to date, when you look at the furthest to the right there, we're a little under 14,900. So because of the increase in the complexity, we're running favorable when we look at this particular cost metric. Any questions that I can answer?
Appendix? Is that where you put appendix?
So here's just one chart on our contract labor, since that's the biggest sticking point when you look at our expenses on our P&L. You could see that while our contract labor FTEs, specifically the travelers, are lower year over year, we're considerably above the target that we established in this year's operating budget. Any questions?
That doesn't make sense. That chart, what are you saying? So the blue is actual?
Yeah, so blue is actual current year. Yeah, and then orange is prior year. So we're lower. So that's good. But when you compare our actual run rate to what our budget is, we're considerably higher still. So that's why when you look at professional services on the P&L, we're much higher than budget.
So we pushed very hard to get rid of those traveling nurses is what
You're
we're
down
trying to say.
25 from last year.
Well, we're down 25 from last year, but we budgeted 50?
Yeah, correct.
We budgeted 50.
But the budget isn't represented on the graph, right?
not-
Yeah, correct.
Yeah.
Great, thank you.
That's it?
Oh, I think it's Greg showing it.
Oh.
All righty, moving on to our next item then. Thank you, Abe and Rick, appreciate that.
Thanks for putting this in the packet, because last time I didn't have it, so thank you.
I'd like to turn it over for our item number 6 to Greg Dieter to introduce and discuss the SJ Health Lodi Clinic.
Thank you, Jay. So SJ Health has been looking at the potential for a Lodi clinic, I think, for well over a year. And in April of this year, there was an engagement with a potential Lodi clinic site with Dr. Fadu and Alice, who are both now gone. And I have in files an August 15th letter of an intent to purchase from a DD Construction that I don't see that was ever executed. But that letter basically anticipated a $10,000 deposit into escrow to do rezoning work. The target property is not zoned for healthcare, and that is kind of a time-limited thing. City of Lodi is working on their 3-year general plan, and we're trying to get the rezoning done prior to, I believe, mid-December. Also in that proposed intent to purchase was placing $500,000 into escrow prior to the expiration of the due diligence period. And then third, a deposit in good faith for the final purchase price, but that final purchase price was ultimately to be determined by addenda executed by the parties in good faith. So little non-certainty on some of those items. Then on September 26th of this year, SJ Health approved $10,000 a payment for the rezoning work. Then the next day, we received an invoice from DD for $19,764 for architecture, city fees, DDC, which I wasn't quite sure what was, as well as a markup of 20%. And I can't see that we actually have any contract or letter of intent or MOU specifically with DD. We ended up meeting with a DD at our offices on October 11th. And also subsequent to that, on September 25th, the Health and Human Services at the federal level provided us an award for a grant of $1.8 million for ultimately furnitures, fixtures, and equipment for a to-be-determined new clinic site. The cost estimates for all 3 phases, so this is a facility in Lodi that would be acquisition, tenant improvements in that facility, as well as net new construction to a total of about 6,000 square feet. And if this was all done, all 3 elements, acquisition, the zoning, the architecture, the tenant improvements, and the net new construction, using prevailing wages, the current estimate is approximately $6.2 million. We're also pending new access point funding from HRSA. I don't know if that's going to come out given where the federal budget is. I don't think we're really relying upon that, but that would be somewhat of a little bit of a kicker to the capital stack here. I don't think that we've done some of the other due diligence, the community needs assessment. Also comment that the community medical centers is building a clinic. They had a groundbreaking actually, or under construction now, not too far away. But the community needs assessment involves gathering letters of support from key stakeholders and actually working with the managed care plans to validate that there is a gap in service need in the census tracts that we would be serving. Also not quite sure if we've really done a fiscal analysis, because, and Chris could probably speak to this, if we stand up this new site, we'd get a new PPS rate, but would get 80% of that preliminary PPS rate until it's finalized, so there have a cash flow issue to some degrees there. And as I mentioned, I don't see any signed agreement with DD. They are in a contingent escrow. They do have some earnest money. I don't know when exactly that the dollar amounts or when that earnest money turns hard. I think they might have extended the escrow. And as I mentioned, there's the timing consideration with the city of Lodi and that rezoning, because if it's not done in hand with the general plan amendment, then there's another more lengthy and maybe expensive process. But I think the other items is this a potentially site to be owned by the clinic or the SJ Health nonprofit? It's some concerns with public contracting procurement if it's not competitively put out to bid, because right now it's contemplated DD would purchase the property, we would help fund tenant improvements, we would lease back and then ultimately buy it, and just other gatekeepers are it's not in our capital budget for SJ Health. Do we extend the escrow, and really we need to get a letter of agreement ultimately if this is going forward. But I know we'd like to get a clinic in Lodi, but I think we're a little cart before the horse, and I just wanted to kind of introduce that to ultimately if we needed a budget adjustment, we'd have to approach the Board of Supervisors as well. So, and Chris, if you have comments?
Yes, thank you, Greg. So just for context, folks, you know, our budget contains sort of expenditures associated with this grant and searching for and finding a Lodi property. But our budget and capital budget in particular did not include sort of buying a facility. We were looking at sites to lease, and we went to a number of other properties and considered, you know, these deals just didn't materialize. This came to us sort of all of a sudden via Supervisor Ding, and we were excited and, you know, wanted to explore the opportunity. And so this is kind of, and then amidst all of the sort of transitions, we have not, as Greg has described, performed all of the due diligence associated with purchasing a property and retrofitting the property and phase 1 and phase 2 and all of these things that DD is proposing. But we did have Lodi and a new clinic in our budget. But again, that was more of a lease and that sort of thing that never materialized. So as Greg mentioned, our capital budget needs to be looked at. If we're going to go forward with this, we just have to go through the procedures of, number 1, performing the financial analysis, number 2, approving the capital investment, and then sort of hashing out the details of the deal itself.
And I'd say that the big outlier really is the public contracting, procurement, and competitive bid, and how we thread that needle.
Yeah, so again, these are federal dollars that we're dealing with, and they're not for purchasing. These federal dollars are specifically for furniture, equipment, fixtures. But that does not sort of alleviate us from performing sort of the requirements for uniform guidance. So bid process, et cetera. We have some legal opinions that say, that have sort of enable us to look at this deal as sort of a sole source vendor, because of our track record of trying to seek and documentation of trying to seek other properties and just having nothing materialize. But I guess that's what I would say to that.
I have a quick question, jumping back to look at your balance sheet, as you both were talking us through it. So under property and equipment, you have just over $3 million on the books. That can't be, is that including the facilities that you have down in French Camp? Or
That's
is that
correct.
on the hospital's balance sheet?
No, the equipment in French Camp came over as of July 1st, 2020.
Okay,
And that's included in our balance sheet. We're amortizing each month, et cetera.
okay, so those facilities, the buildings included?
No, not the facilities.
Okay,
the
that was my
equipment.
question.
No, not the facility. We're
Okay.
renting from the hospital. We're
Okay.
leasing from the county.
All right,
Yeah.
that makes a lot more sense. I'm thinking,
Yeah,
man,
no,
those are
we have
some
no
cheap
property on
buildings.
that balance sheet.
Okay,
Yeah.
so this would be the first building
This would be
on
the
the
first.
balance sheet?
This would be the first.
Okay, that's what I wanted to know. Thank you.
That was my question. How many buildings do you guys own? I mean, going forward?
Zero.
Zero.
Yeah,
So the question I would pose, and, you know, we wouldn't know the answer until we really could project what the new PPS rate would be, what that 80% looked like. But remember what our goal is here. So our goal is to make sure that the county as a whole has access to care, right? So, and we all know CMC is a reputable organization, correct? We know that they're a decent FQ. So it seems like we're competing for a market that that reimbursement doesn't cover our costs. So if the issue was access, then I can understand us being in places where there is no access, right? The worst places in town is where the FQ should be. But I don't understand is why we would, let me rephrase that differently. The question would be, why would we want to, in a sense, inundate a place like Lodi, let's just be honest, who has a much, much more favorable payer mix and much, much less Medi-Cal participation than the rest of the county? I guess the question is, are we chasing CMC to try to be competitive, or are we looking at the county overall and saying, where is lack of access and how do we make a difference there? And by the way, when you go to those lack of access places, the real estate is gonna be a lot less. So just a.
So you're saying we're duplicating services, basically?
Well, I'm saying there's access already there. And so what are we getting for that, you know, how quick are we gonna pay that capital back in a scenario where, as it stands right now, unless the PPS rates don't significantly increase, we're kind of losing a little bit of money on every patient.
so let me ask this question, not to put anybody on the spot, and I maybe have an idea what the answer is. How did this whole thought of having a Lodi clinic come about?
This opportunity came to us via Congressman McNerney's office.
Okay,
And I guess this would be his service area.
okay,
And so we followed the protocols to have these federal funds issued. And so because this is his service area, we have to use these funds for that area. That's it.
But it's also in East Lodi, which I think is underserved, but I think we need to validate that. How many Medi-Cal lives there can we capture, and can we actually not only meet the need, but
Did you guys get that earthquake note?
Yeah.
Nobody's ducking under the thing? All right.
They made me
Okay.
turn my phone
All
off.
right.
There was a needs assessment performed, and that was somewhere around 2021-ish. So we have that for the FQ. Lodi was definitely one of the zip codes. So are we competing with CMC? I would say we're always competing with CMC, but we're always working together with CMC for the benefit of the community. Anecdotally, I'm from Southern California. We put FQs right next to each other because there's plenty of demand. And so I don't think that there's sort of a disadvantage to having like businesses together. In fact, it may be a draw for the community. Having said that, we have not done a needs assessment for this specific area, and if we need to do that, we will go ahead and do that. Again, this was an opportunity that sort of Dr. Fadu worked, and our government folks worked with McNerney's office, and we're just trying to perform on our agreement now.
okay, thank you.
Chris, I think I heard you say that you have a legal opinion that you are able to purchase this using the concept that this is a sole source. Can you tell me who that legal opinion is from?
We had
And are you able to share that with us?
We have contracted Chronic as general counsel services for the FQHC. And this was not a written opinion, but a verbal opinion. So, I mean, I guess we can produce something.
Well, I think, because I comment on that,
Right.
and it was because of exigency, you could get around things, and so I think we need to do some more due diligence. I don't know, after we met with Dee Dee on the 11th, I'm not quite sure what additional expenses they're putting in until we can commit, if you will. There was going to be their attorney working with our attorney on the deal. But really the linchpin here is they're in escrow with earnest money. I don't know the terms of the escrow because we're not a party of it. But if this particular building is what truly we desire, there is that general plan amendment that I think we don't get the rezoning done by December. It's a much tougher, lengthier, expensive pathway, but I don't realistically see an ability for us to get our ducks in a row by then.
So, in layperson's term, how many variables are there? 10 variables? Okay. So you run the problem of sole source, you run the problem of owning it as opposed to leasing it.
That's right.
And then you have less liability long-term. I mean, there's the service provider, duplication of services, 3, 4.
But it's a public works project, so we have to do items that SJ Health might not be that familiar with, as is general services. There's some hoops to jump through for compliance, but I think the large one is, should ultimately the property be in the name of the nonprofit or the county?
Yeah, tax ID is an issue.
Okay, have you gotten any sort of direction from the clinics board?
Only that we committed the $10,000 because we weren't able to go anything larger, but given the urgency of getting the rezoning work done, we did approve $10,000, and I believe that check has been cut.
I believe so.
Has anybody looked at it from a business perspective?
Like I said, I have not seen the pro forma, because can we staff it, can we operate it, and indeed, can we cash flow it, because we'll only be getting 80% of the PPS rate, the cost rate, so 20% of our cost has to be covered with other buckets.
So with any FQHC, it's always cash up front. I mean, there's always an investment. You're not gonna see these funds recovered for year and a half, 2 years in the traditional environment. In the public sector, things seem to be moving a lot slower than what I'm used to in the traditional sector. So the cash sort of commitment may well be longer than that. In terms of our budget, I think we projected 2 full-time providers at the Lodi Clinic initially, and not for the entire fiscal year, half of, so beginning in January, as sort of something to put in our budget, backed by our, what we know about our recruiting efforts, et cetera. Again, we need to look at this from a larger picture now, because we're considering the idea of purchasing property versus going into something that we would just have to renovate and lease.
And I would also comment that East Lodi is a designated health professional shortage area, so it meets that metric, which allows us to be flexible with visa physicians.
So help me understand, there was an economic incentive from Harder's office in order to do this. Is this my earlier question? This was the
McNerney.
Oh, McNerney, I'm sorry, yeah. So this had been from some time back.
Yeah, this was an effort that took a while.
And what was that economic incentive?
So they announced an opportunity for funding,
Uh-huh.
and our grants folks and our leadership team answered, we letter of intent or some sort of communication to McNerney's office, and then we took direction from them in terms of pursuing the funds.
So similar to county put in some earmarks with our federal designation, delegation. So SJ Health did something similar.
Okay. Are we obligated, have we, how do I want to say, have we taken benefits at all?
No,
from-
so we haven't collected any of the funds. We haven't purchased anything to be able
Okay.
to draw on these funds. There's nothing to give back at the moment. It's just an agreement,
Okay.
and we may or may not perform.
Okay, so given the economic incentives to do this, and coupled with Rick's questions and issues earlier, and all of that combined, what you just mentioned about, you know, the slow pay, the year and a half, you know, until you start getting traction on that, how does this economic benefit from McNerney's office factor in and mitigate that?
I don't think so. Of the 1.8, the detail is 558K for equipment, 1.36 million for construction, alteration, and renovation, and 78,000 for other. So I don't think there's really you know, an ability to supplement visit revenues.
Okay,
This is all cost reimbursement.
got it, okay, I understand it now.
But we would go through the initial rate-setting process. We've just seen that our average cost per medical visit's $331. It's this type of figure, 300 plus, that we would anticipate receiving as a result of the prospective payment setting process.
Okay. So essentially, whatever economic benefit would be to get the thing up and rolling as a cost offset.
Correct.
Okay, thanks.
I find it interesting that you have furniture before you have the building, but just.
But we have funding for
Call that
furniture.
straight.
Funding, we haven't bought anything.
I'm thinking,
Woo!
right, I think, anyway.
I wanted to add something as well. When our office met with the government affairs director for the clinics, who was telling us about the desperation of finding the site, we just went to a contact in the community in conjunction with the Lodi Healthcare Foundation, and they got the ball rolling right away and found the site. And one of the ideas for the site originally at the beginning is to get a mobile health clinic out there to help you with your billables. So if there's something in the interim that can be done there, that would be helpful.
And that's a model I think ultimately I think the clinics should emulate. I've seen other FQs where they set up the mobile van, do an episodic site under 20 hours a week, build that at the highest home office PPS rate, establish the patient panel, and then backstop that a couple years later with the brick and mortar.
Yes, we can actually do 40 hours a week now. Yeah. So, yeah, we definitely have a mobile that we can park out there to sort of, you know, increase demand and meet patient need, as it were, while the clinic is being built.
I just have one question. So the 80%, when, does that ever change? Or you just get 80% for perpetuity, or does it go to 100%?
So there are
and then you
two
actually-
processes. One is your initial rate setting, and then the other is subsequent to that. You've received your initial rate, and now you'd like to change it, which we have the ability to do. The 80% that Greg was referring to is part of the initial rate setting process. And Audits and Investigation says, thank you for your paperwork. I see your calculation. As an interim rate, we're gonna issue a PPS rate, an interim PPS rate of 80% of that value. So that's what you sort of collect on, while the state goes through the process of auditing your documents and your costs, and which can take considerable amount of time because we are considered an affiliated agency with the hospital, so their Medicare, Medi-Cal cost reports need to be audited for that fiscal year. In this case, in this case would be fiscal '24, and that could be another 3 years before that's audited, before the hospital cost reports are audited.
But ultimately, if the audited report comes in at 98%, you'll get that 18% as a lump sum.
That's
back to
correct.
the initial designation.
Yes, once all of that process is done and the state has issued us our final PPS rate, any retroactive, that 20% will be paid out to the FQHC.
So the 80% is the $331 then?
We'll say, yes.
All right.
On the, there's other factors that can stimulate a restructure of the PPS rate, correct?
Yes, this is just in reference to a new clinic at Lodi.
So
There
Right.
are,
So we could go through the same process of re-establishing the PPS rate, get that 80% without the new building. I'm just letting you be aware of that.
the purchase of a building is not a requirement for, it's just, what are your costs for the new clinic? And we just put in all of our costs. In this case, we may or may not purchase a new building.
But it could be up to 3 years before you get the other 20%.
Yes, that's the reality of
5
where
years?
we are here. Somewhat different than the traditional FQ space.
Thanks.
So we're just really looking for dialogue and direction. I know SJ Health Board will have some conversation on this at our upcoming board meeting, but I just, like I said, I think it's difficult to get our ducks in a row in the time frame, but obviously a lot more due diligence we need to have done as well.
I would agree. Thank you. Are we ready to move on to the MOU walkthrough? Item number 7, again, Mr. Dieterich.
So I'm sure that our hospital partners will have comments, but really this MOU is between San Joaquin County and SJ Community Clinics, rebranded SJ Health. It was entered into effective July 1st of 2020 when the FQ was fiscally separated from the enterprise fund of the hospital. And that's, I think, when Chris also just mentioned how when we acquired assets on our books for furnitures, fixtures, and equipment. The MOU outlines the services that will be supplied by San Joaquin General Hospital, as well as various other county departments, purchasing, HR. The term is 5 years. There's a 6 months termination clause, and it requires that the co-applicant agreement also be in effect. If there's any material dispute that cannot be resolved by the impacted departments of the MOU, it requires the co-applicant agreement dispute process being called up, which is the liaison committee. There's 10 parties that are signatories to the agreement, including myself as the Healthcare Services Director, because there's a behavioral health can supply mental health and substance use services to the FQ. The MOU essentially has 21 sections. I'm not going to scroll through it. It's in your packet. These 21 sections are related to essentially scopes of services that are to be purchased by SJ Health. Many of them have fixed percentages of an SJ or San Joaquin General Hospital cost center. Then after those sections of the MOU, there's Exhibit B contains a percentage of the quality incentive pool plan earnings that are already be transferred from San Joaquin General Hospital to SJ Health, and I know that's an item of concern between the parties as related to how we maximize that pool and how the funding is ultimately appropriately allocated. There's other addendums to the MOU for the hospital transfer agreement such that they will accept our ambulatory patients into their inpatient setting, as well as residency program rotations within SJ Health. I would note that on February 17th of this year, Dr. Fadu provided 180 days notice to cease the purchasing of medical informatics services from San Joaquin General Hospital and essentially no longer pay 40% of the monthly expenses specific to that San Joaquin General Hospital cost center. I don't know the status of the due to, due from accounting regarding that, but it doesn't seem in my reading of the MOU that piecemeal changes can be done in that fashion. But I think the MOU is stale, in my opinion, and I know Chris could talk a little bit about my next statements here, but my real concern is that these various fixed percentages, you see 20% here, 40% there, they somewhat seem to be arbitrary. I don't think we've been able to find any real, and this goes back, 3+ years, any real analysis for the underlying allocation methodology. Many of them, I don't think they will survive a cost audit. That's really my concern, given that we've been using fiscal year 23 as a new base year for some of our PPS clinic rate changes, and will they pass audit? Like I said, these are like fixed percentages. I don't see an allocation methodology based upon full-time equivalent positions, gross square feet, number of transactions performed. So I think the parties really need to look at the overall MOU, modernize it, and get it set up so that these due to these allocations will pass a generally accepted accounting principles audit. And I just really wanted to introduce the MOU to the wider committee and suggest that SJ Health, San Joaquin General Hospital, and the CEO's office kind of work collaboratively to make needed updates to it.
So, no, let me comment real quick because it's really important. So prior to the separation, all of those services were covered at the hospital. FQ separated, went out and duplicated most of those services for added cost. Nothing changed at the hospital. Nothing changed. We could have done it, we did it then. We could have continued to do it now without all those additional people that were added on to the payrolls for duplicate services. That's issue number one. Issue number two is they extract, as a CEO of a hospital, I would have never, in fact, if I had 100 CEOs of hospitals here, 99 of them would have never signed this MOU. We asked to get out of it early. It doesn't make sense from the hospital perspective. There used to be 50 public hospitals, and I say that because now there's 21. So we understand the challenges that are there from a public hospital perspective. For us to be, and in none of those cases, in none of the 21 current public hospitals does a single one of them share QIP money with the FQ. So we've increased costs significantly, and we haven't provided, and all the services that were provided at the hospital, nothing changed there either. So it wasn't like we let go here and hired there, right? So we, thank you, Greg, because we do want to renegotiate the MOU, and we want, this is the important part of this, we want a true collaboration. We want to work with SJ Health, and we want to work with the health plan, and we want to work with behavioral health and public health like we're one entity moving forward, instead of 4 or 5 silos that are duplicating costs across the continuum, including things like all of those people that sit at Spanos had office space at the hospital. Let me say that again. All of those people that sat at Spanos had office space at the hospital. That, whatever we spend a month there, in Rick Castro's opinion, from a taxpayer's perspective, is 100% not the right thing to do.
I'm not going to comment on Rick's comments. We're here to work collaboratively, and what's happened in the past, there's been due diligence performed by many of, not just the clinics, many county offices, county council, the administrative office, in putting this document together. I'd like to address Greg's specific comments regarding the percentages. My story doesn't change from last month to this month. We had informal departmental surveys conducted by the hospital's CFO, Chris Roberts at the time, to sort of come up with the percentages that we were paying specifically for the hospital services. Why this is coming up, and so I'd like to provide some context to you, Supervisor Canepa. We knew that we were using fiscal 23 as a PPS rate rebasing year for 3 of our clinics. We're currently completing the cost reports for that, and we will be shortly by November 30th, turning that in to the state. Part of our cost structure definitely is what we're paying to the hospital for these services. So I approach the state proactively and say, hey, these are our documents. We are a county affiliate, we're et cetera, telling them who we are. And showing them the basis for our cost structure. In doing so, they asked us, what are the basis for these particular percentages that you're paying the hospital? And so I told her they were informal surveys. I also checked with the hospital. And I asked Ashley Reinhardt, hey, look through Chris Roberts' emails, look through the supporting documents that you have. We need to know the genesis of this stuff because the state's going to need to know. And she returned to me, I have nothing but what we provide our annual cost report auditors, which is a one-page Word document that essentially says what I just said. It has the percentages, and then it has an explanation describing the nature of the surveys. I will say that the IT allocation that we receive does have a more formal methodology in terms, I think we use FTEs, so that would be something that would potentially be fine. But in general, that's what's submitted for purposes of the hospital submitting their Medicare, Medi-Cal cost reports, which they have done for both fiscal year 21 and fiscal year 22. And that particular support document has never been called into question by the feds or the state, right?
Yeah, correct. There haven't been any cost report findings on the hospital side connected with the MOU.
Right.
But to Greg's point, I do agree that we need to revisit these allocations and look for ways to eliminate redundancy and, reduce waste, right? I mean, that's what's best for our patients.
Okay, so, but to more the point, this is not at risk of not sort of passing a gap because we are a customer of the hospital and they are a customer of us and we've agreed to a price. So it's not like our financials are misstated, but for the purposes of rate rebasing or our audits and investigations saying, okay, this looks good, here's your $331 per visit. They're wanting to take all of the hospital expenditures, all of the FQ expenditures, and perform some other methodology because all we've collectively as a county have been able to provide is a one-page Word document supporting these percentages. I think there's a question you have.
Well, no, so then the question is, could you eventually get enough money to wean yourself off of the quit money? So that would be
That would be a question.
so that's the thing. I mean, because
As
that's
I
what Dr. Badu said. Oh, well, eventually we could not take that quit money when I went to visit them on California Street. And that's, for me, as a layperson looking in, there's a lot to learn. But I mean, that's the thing. How do you wean yourself? How do you not duplicate services? And I mean, just like this new venture, it's like putting the cart in front of the horse. I mean, and that's some of I was looking at these percentages and I don't understand them either because I'm not in this. But I mean, for somebody just to throw a number and then this is what you're going to do and then never revisit it afterwards to say, hey, this number's working, this number's not working, we're paying you too much for this, you know what I mean? Because it can go both ways, you know what I mean? They could have problems. But if we're duplicating services, this all needs to be looked at. And I don't know if this is the first step in it, but I mean, it's just like everyone's kind of been doing their own thing. So I don't know how.
Well, the issue of duplicating services, we really have to define that and look at it and use more than just somebody saying that we're duplicating services.
I got a great idea then. So let's take the total cost of the clinics from 2020 before the separation. Just for this committee, I think it would be really good to look at the total expense of the FQs before the separation and look at the total expense after, because I think that will tell you everything that you need to know in regards to how we're not moving in the right direction as far as expense goes.
But if we do that, we have to honestly look at the same allocations for all the departments because the hospital doesn't have an indirect.
I'm talking
journal.
about total cost. I'm saying,
Yeah.
today we ran, because I can tell you what the numbers are. In 2020,
No.
the expense was 21 million, and it was 38 million now.
And I don't want to past is the past. I see this as an opportunity for SJ Health and the county and the San Joaquin Hospital to come back together. Because indeed, I think part of the play, if you will, with getting a new PPS rate and ramping up those expenses was now that we can get those covered by an enhanced PPS rate, wean ourselves away from 36% of the QIP to something smaller. But I think when you mentioned no FQ gets QIP dollars, we're organized a bit differently in our county because all the other public hospitals, they all have FQHCs that are a lot closer to the county and the hospital. How can we do that? Because ultimately, as you mentioned, Rick, all the legs of the county healthcare system, be that the hospital, the FQ, the public health, behavioral health, let's work together. We've had a very productive QIP meeting, working meeting. How can we maximize the dollar amounts of the QIP coming into our county and then having a collective decision where best are those dollars allocated? And indeed, if we get enhanced PPS rates, we can wean ourselves away from a diversion of those dollars into SJ Health and be self-sufficient. But I think overall, the whole picture needs to be looked at. Have we ramped up costs? Can we sustain those? Or is that the best spend? We got to look at this as the entire county's healthcare space.
Also-
I agree 100%, and that's what I'm trying to do, and why I'm so adamant about this, guys, is you look at a hospital that is struggling to break even, and supplementing a FQ that's showing profitability. It's not a true fact. So when you look at Contra Costa and you look at Almeida, who both, by the way, are 100% of getting 100% of their QIP money, so they're doing it right. They funnel all of their departments, and Almeida is exactly like us. I think they even have the prison contract. And they funnel all 5 of the healthcare components down to the single dollar, but it allows you to say, which one of those structures do we need to focus on, because that's where the biggest bleed is happening. That, to me, is the model that we should shoot for. And yeah, I'm passionate about it because I am fiscally conservative.
So
I do not like to spend, I don't understand when all of these services were done under the hospital, then if we did this transition, we should have reduced our staff significantly because we no longer had it, but we didn't, we just duplicated.
So Rick, I'm probably the only one in the room here that was, and Chris came on kind of midstream to
January
this thing.
2020.
Yeah. So I had been in these meetings, I think since like 2014, right. and gotten into pretty much the weeds of the financials, which is why I made my very positive comments at the beginning of this meeting. And I got to tell you, when those clinics were treated, and I'm not picking sides here, I'm just telling you what I saw as a referee, is the clinics were treated as a department of the hospital. And my understanding at the time, because the financials were not super clear and they were all over the map and, there were numbers on a page, right, is a lot of those expenses as well as the activities were commingled, okay? And one of the things when Chris came on board that we had to do, because I was in the auditor's role at that time, and breaking that apart was so difficult because of the fact that you had salt and sugar mixed together between the clinics and the hospital. So I think if you're trying to go back to pre-2020, you're gonna have a lot of kind of confusing unwinding. And what you're not gonna know is, my understanding, okay, this is the best I can recall it somewhat 3+ years later, is you had docs that were jumping back and forth.
Still do.
Okay, but the costs weren't even being tracked. So, you might have a doc that was doing work in the clinic that wasn't being billed to the clinic for that allocation. You also had costs that were being incurred by the clinic that weren't being charged to the clinic. And all I'm trying to say is, it's not like you can dig far enough down in the detail and you're gonna go, aha, well, now we'll re-separate it. Because when we went through this, there was nothing to separate. It was just like you never put anything in your check register and you wrote a bunch of checks for a bunch of years, and now you're trying to go back and figure out what you did. That's kind of how everything was. It was almost having to start from scratch. Now, I agree with what you're saying on a forward-looking prospective analysis. We absolutely want to do that stuff, but I'm trying to caution folks that if you try to do a forensic analysis, it was a mess, And you're not gonna be able to see it, because even if you were able to separate those numbers, you're not gonna know if they're accurately representing the activity that occurred.
Exactly.
Yeah, and the only thing that I would disagree with you on, Jay, and again, we're moving forward. Our goal right now is to make sure we maximize the QIP, and Dr. Dulio is doing a fabulous job on making that happen, and I think the hospital's helping by opening up mammal spaces and all the things we should have done all along. But the duplication that I'm talking about is HRD, CNO, blah, blah, blah. All done, all duplicated, all increased expenses in what really was a scenario where, as is all FQs, a struggle to stay positive.
Understood?
My question is then, you did this, we did it, I mean, you made somewhat of a better circumstance, it seems like, but I don't know that you ever go back and revisit. So I mean, so you did this agreement, and you threw it on the wall, and is it sticking on the wall? So I mean, and there's a lot of different variables, who's in charge? The co-applicant agreement obviously does this, but I mean, what are the checks and balances? It says you can get out in 6 months, great, but I mean, who,
Well, that's
so
not-
we have another board
That's the county and the clinics, not the hospital and the clinics.
Which is what Greg said at the beginning of his presentation.
But this is an opportunity for all us to get together, align, we sink or swim in healthcare and specifically on the QIP together.
I agree, 100%.
Or
Yeah.
you blow it up. I mean, if that's the thing, if somebody's not agreeing with what is going on.
But if
Because I
we-
mean, it just seems like there's been so much tenacity and, you know, it doesn't, I mean, I know we need to work together, but it doesn't seem like it's been that way.
But
So
it's a new day.
Well, no, I get that, but I
And
mean,
if we
so-
blow it up, ultimately our mission fails for taking care of the vulnerable patients we're seeking to serve.
Okay.
Well, I didn't, he didn't say blow it up and not do it. So that's a whole different scenario.
So if we do sort of blow it up, to use the term?
Sorry.
No, it's fine, it's fine, no, it's fine. Just to understand, we risk our federal designation of an FQHC look-alike, and we risk the enhanced reimbursement as a result, just so that we all have the same
No,
understanding.
I want to fix it, obviously.
Yeah,
but
yeah,
I
right.
mean,
Right.
there's,
It's a new day and a lot more
Sure.
recurring engagement and constructive dialogue between the
no,
parties.
it's good. I think it's great, but I mean,
It's
if
just-
if something's not working and then you have a document that's not working, then something obviously, I mean, you know.
Well, I'm gonna punctuate something Greg said in the beginning of his thing, because as auditor, I did the cost allocations for the entire county, right? And what, they're called allocation units. And what Greg is saying is we wanna have an allocation units-based formula for allocating costs, not to go, Kentucky windage, it looks like 15% or whatever. I didn't work this up. I was the county administrator when this all happened. But if you're gonna base it on square footage, on personnel, on, you know, whatever other allocation units are accepted units for that, then you can rationalize what those numbers are all about, and that's what we need to do.
I think that's the biggest part for me coming in. I mean, I don't know how this meeting hasn't occurred in a year and a half. That just blows me away. I mean, it's just, you know, kind of malfeasance. But how do you fix it going forward so that everyone still doesn't duplicate services? I mean, we need to lean this up. I mean, there's so many problems that I see, and I'm just a car wash person. I mean, and if I can figure this out, then this is not good. You know what I mean? And so I mean, at least we're talking. I mean, I appreciate it. But just from me seeing this,
I'm gonna give you a short answer, Supervisor. What happened is, the hospital is a $450 million animal that was badly in need of help, okay? And so we were focused for almost 2 years on getting an MSA agreement together so we could make sure that thing didn't plow into the ground and take a chunk of the county along with it. At the flip side, the clinics, which we had to, because of an audit thing that happened in 2020, I believe,
Correct.
was a $15 or $20 million operation. And we kind of focused on our $450 million entity to get it sorted out. Meanwhile, we had some things that started to develop here, which we're now roping back in. I completely agree with Rick that there's duplications, I would believe, that need to be looked at and all of that. But there are also valid cost allocations that we never did prior to 2020 because we just lumped them in as a department. Right. That in order to maintain that approved separation, the FQ status and all that other stuff, we actually have to have, and they have to be supported.
right, but I mean, even like the setup of the board for the clinics, why there's not a supervisor, why, you know what I mean? why there's not just a little bit of more, and I understand the independence of it, but I mean, when money is flowing through and you have it coming through us and there's a co-applicant, just like continuum of care, same idea that drives me nuts, who has skin in the game that actually is part of the flow through of the dollars. You know what I mean?
HRSA precludes having a county employee on the board, but this is all us collectively this is an avenue for us to repartner.
So then, HRSA, but if it was still under the county auspice, it's,
Would not matter. We are a look-alike because our governing board, the 5 boards of supervisors, not meet the demographic requirements of HRSA. Therefore, we have a co-applicant board that does meet that demographic requirements, 51% of them being clinic users, but also representing the ethnicity and the socioeconomic status of our clinic users.
so then
I
how-
believe the
how is it-
hospital needs to be part of it as well.
But how was it ran before? So what caused the split originally? I mean, it was, so is it the HRSA part of it, or is it because it was losing money and so they would cut it off, or?
Do you want me to?
Well, I have some history here. I pushed for this well prior to 2020. My understanding, it's a HRSA program information notice that they need to be separated on a balance sheet basis, so the retained earnings of the FQ should not be commingled with the enterprise fund, and that was, I think, some of the nexus of the audit.
Which got triggered in a financial audit because as a consequence of what Greg said, the co-applicant agreement got updated, and as an event, our auditors caught it. Our former auditors were hospital specialists, and they went, oh my goodness, look what you guys did and look what has happened or not happened. And so that whole thing kind of happened. 3 years
Plus
ago.
the existence of the corporation
Yeah.
that was established in 2012.
So then what?
No, the corporation was 2010.
2010,
Which
excuse
county
me.
were you talking about where it's still together?
But
Well, then how's that occur?
we are atypical because in Stanislaus County, it was where their FQHC was a lookalike. We didn't have a public hospital, and therefore we didn't get quit money back then, or DISRIP or Prime. It's been a couple of different iterations. But their nonprofit board was not a separate 501c3. I think if you look at CAPH, you're not going to see a lookalike partner that's separately incorporated. So we are unique in that aspect.
And if we had gone back and altered any of that, our PPS rates would have been set.
The designation would have been
Yeah.
threatened.
Yeah, so we were kind of stuck. We had a bit of a Frankenstein, if I can use a layman term. And if we changed our Frankenstein, then there was an economic consequence.
You'd be hard pressed to find another example like us.
Well, as currently constructed, if the hospital did not provide those shared services to the FQHC, then San Joaquin Health would have to go outside of the hospital for those same services, right? Probably at a higher rate.
I don't know about a higher rate. We pay over $1 million for housekeeping.
But the
or facility.
difference is that.
But they're duplicate.
Yes.
That's the issue. They're duplicate. We did them before with the same people. We added twice as many people to do the same service.
What is best for the county overall is my perspective, and can we share services? Can we collaborate more? We don't need to duplicate, but yeah, we have, it's a new day and new opportunities. But I think looking at this, hopefully we can roll up our sleeves and collectively come to a new agreement and new collaboration.
Greg, we're 100% with you. I just want to make sure that we understand that we don't just say, okay, the past is the past, let's move forward. Let's learn from the mistakes of the past. That's all I'm trying to say. And like we do in everything that we do in healthcare, we look for the place that's doing it well, because we don't have to reinvent the wheel. And that's why I bring up Alameda, thank you. And that's why I bring up Contra Costa, because those are places that have done it well, and we should look at how they did it and try in our best case scenario to deliver healthcare. And remember this piece of it. If the FQs if we can't get to the PPS rate that covers our costs, and remember that even when you do, that PPS rate stays pretty static. I mean, it increases like less than 1%, right? If we can't get to that point where we are, where it's not costing us money, would there be other better alternatives from an access perspective? Because what we're trying to do is make sure the most underserved patients in the community don't end up in our ER where it costs them a fortune, right? Where they get taken care of at the clinics. So when we talk about what we talked about yesterday, that public-private partnership, is there a better way from the existing places out there? If the end game is every patient is gonna be a cost to us. Do you understand what I'm saying?
I understand what you're saying, and what I also would like everybody at the table here to understand, this team can do what you're talking about.
Absolutely.
The prior team, no, okay? So we are where we are. We got the caliber and the quality of folks to pull the whole system together, to get it figured out, to become the best well-oiled machine organizationally that we can. But I'm telling you, the prior group could not do this. So it's not, it didn't get this way overnight. I've been here 10 years, and it was this way when I came on board. So we should consider ourselves fortunate that we got the players who we have right now, which we do, who can get it done.
And I just echo when Rick said Contra Costa and Alameda County. Those counties are now what's termed county organized health systems, which means the managed care plan is the county. There's no choice. We're lucky that we have a local initiative health plan in San Joaquin, 93% of the market share. I think that's also something we need to leverage more. Even though we're not a COES, let's work with health plan of San Joaquin on supporting the public systems. County organized health systems. So we're a two-plan county model with a local initiative, Health Plan of San Joaquin, and a commercial competitor, HealthNet. And those other counties, there's only one managed care Medi-Cal plan, and it's generally county organized, like Orange County, Merced.
Wouldn't it be advantageous, though, to have one healthcare plan? Is HealthNet helping us? Because it's certainly.
Well, we had an opportunity 2 years ago, prior to the re-procurement of Medi-Cal. We went with the regional expansion, but I think also there was, did we want to reduce choice for the Medi-Cal consumer?
So, Supervisor Canepa,
Now that I'm more confused, no?
you asked, right, exactly. So you asked, can we work towards eliminating the need for allocating QIP dollars to the FQ? Eventually, yes. It's not overnight, but also no. We've lost the ability for the initial rate setting process on these clinics. That was the first setting. Subsequent to that, we can rebase, but the state automatically, with no audit, with just the way it is, there's a differential of our old PPS rate and the calculated new cost per visit. And the state takes 20% of that differential, and you never get it. You will be audited, which will take years, but you will never get that 20%. So that PPS rate will never cover 100% of that cost per visit. It's just the way the system's designed. You need to make it up with volume. And we can. Right, increase access, but you just know that from a pragmatic standpoint.
But Chris, unlike the initial base where eventually you'll get that 20%, in this rebase, you won't, that 20% until it's finalized, you'll never get that back, but once it's finalized, you get the new PPS rate, so you have the go forward, but in our case, given that we're CMS audit with the hospital, it might be 5 years where we're never gonna capture that rebase 20%, but after it's done, then we will have it.
But you don't get that 20%.
Ever. No, guys, don't misunderstand what I just said. The differential between the old PPS rate and the new PPS rate, let's call it $100 difference. Even in the best case scenario where all of our costs come in line, are accepted, signed off by the state, the best case scenario is 80% of that differential. So $80 in my example of 100. In the best case, now these auditors are looking to disallow costs. So that process is good. So that's the best case scenario.
Yeah, so hospitals, clinics have a high percentage of fixed costs, so it's critical that we drive utilization up so we can, spread that fixed cost over more units essentially.
You increase your volumes to make up the difference. Just know that this, for your edification.
Just another variable.
Yes,
Just-
yes, yes.
Need more people.
If we're perfect, we don't, get 100%.
Anything else on this, Greg?
Hopefully, the parties can get together and work collectively with our boards on new beginnings and correcting issues and addressing concerns.
Thank you, Greg. At this time, we'll have committee comments. Is there anything any members?
One other thing that I'd like to put up for this, to this board, because I think it's really important. We have UAPD contract coming up, which is our physician union, which.
Your microphone.
We have the UAPD contract coming up, which is the physician union. So first of all, a physician union is very painful, right? It's not something that I'm used to seeing. From a professional perspective, it's just not the way most docs would go, but I understand why they did. So our docs are paid very well, and they have to be because it's, to attract doctors to Stockton is critical. But in the current contract, there's no productivity, and there's no, the incentive programs are all achieved in the first 4 months. So is that an incentive? It's called base pay, right? It's base pay. So I am advocating very much that we put in productivity standards for our physicians, and that we also look at, we make the schedules. We dictate when the clinics are going to be opened. We have a number of docs that, and this is causing problems in the hospital, and it happened a long, long time ago. If you have allowed physicians to go to 410s, right? And your clinics are open for 8. You've lost 20% of your productivity the day that you did it, right? And that's where our FQ physicians are. They're in 410s. Their clinics aren't open. Most of the clinics aren't open for 10 hours, right? They're quote unquote going to do their paperwork at home. No. So we have to be more aggressive in, I think, run by a physician, given to physicians. We have to be more aggressive in making sure that we have standards, right? I have some docs that saw 2 patients in one day. We got to mandate from a payment perspective that there has to be a productivity standard, even if it's at the 40th percentile. Just something for us to make sure that we get what we need and are able to change schedules based on what the community needs, not what's the word, balance, right? Because balanced life is a 40-hour week. Nobody in this room works a 40-hour week, right? We all work more than that. So we can demand that of our highest paid personnel as well. And I only bring it up because I have Brandy here, I have you here, Jay. You guys are going to be instrumental in that UAPD contract. We need to make sure that we have some ability to hold it, to improve our financial performance based on what we do basically in the public life is make sure we get enough units per visit.
And Greg's also impacted by that. And has had some experience with it too.
And we have no physician sitting on those negotiations. We don't have.
From management's perspective.
From the hospital's perspective, we have no physician sitting in. I just don't get it.
CEO Castro, if Dr. Capre would like to sit in, she may.
We'll have this discussion after, because we were told,
That's something we would have to talk about.
We were
It has-
told no.
It has to be a management physician.
Okay.
Supervisor Canepa, just for the sake of clarification, our clinics are open usually from 7 to 7, so 12 hours. And then we have 3 days where some of our clinics are open from 7 to 9, so 14 hours. Just point of clarification.
I have a comment. So at our SJ Health Board meeting later on this month, there's a slate of officers. So if it is passed, it looks like it will be Brian Heck as the chair, Cynthia King as the vice chair, and Rod Place as treasurer. And I bring that up because I know the liaison committee, which is to be stood up if there's disagreements between the parties, I don't think has ever been called up. I understand that there's an opinion that that's kind of a Brown Act meeting. I'm kind of wanting to have the members get to know each other, get to understand the issues a little bit more informal, and I wasn't sure if we didn't call it the liaison committee, but if I took two board members of the two supervisors, two board members of SJ Health out to lunch just to kind of get to know each other, have some frank discussions, but it's not the formal liaison committee. Is that a Brown Act violation?
Well, we have the situation, we're still waiting for a waiver of any conflicts, and so we're in a tough situation. I would just say generically, it doesn't, if you're talking about less than a quorum, and this is not particular because I can't be giving advice at this point, but it doesn't sound like a Brown Act problem to me.
It'd be lunch, it'd be less than a quorum, and as far as the council conflict, that's something I'm attempting to unwind.
Look forward to it.
Are there any other comments before we go to adjournment?
No, I mean, you guys are gonna have to bear with me. The learning curve is a little bit daunting on this one. But I mean, it is the best interest of me to have everybody served in a timely manner. But I mean, some of the stuff in government just absolutely blows me away. This clinic. I mean, we were just at the groundbreaking for CMC, and it seems like they're putting one hell of a clinic, and then people say that they can't get folks to their clinics. So it's like the Lodi thing needs to be looked at before you all are gonna come back and need, I don't know, $6 million out of general fund. So that due diligence, and I know Supervisor Ding's probably chomping at the bit because it's in his district and it's his people. But I mean, I think that's what's gotten kind of everybody in trouble, is you have this grandiose champagne, ideas on that little beer budget. And I think when you start to do more, you better make sure that you at least have the people to do it. And I don't even think we have the people to do it. So that's the most important part. And some of the alarming things that you're talking about, somebody's getting paid for 10 hours worth of work and sees 2 patients, that's absolutely alarming. So that, to me.
Just for clarification, that wasn't on their side, that's on mine.
No, I'm just saying, any side. I don't care what side. That's embarrassing. Get me that job, please, so that I can do that.
You gotta see 1 at 8 and 1 at 2.
Yeah, right.
I already applied,
So, though, you know what I mean? And I know it's not the norm, but I mean, it's pretty alarming when that comes up. So for somebody like me to come in and try to figure out how we're gonna marry all this back together and be successful is the important part. I mean, I'm glad to be a part of it. I wish I could bring more expertise. I don't understand all of this, but I will learn it in time. But I think it's important that we do all work together collectively and figure out, labor, cost sharing agreements, and make this a living document instead of something that's just thrown on the wall, and hopefully it sticks. So
Supervisor, I think if you saw the collaboration that's happened over the last month, you would have a much better opinion of where we're going, and we're going in the right direction. So I don't want to make sure everybody understands that, Greg's done a great job in bringing the docs to the table, and the docs are working with their fellow physicians at the hospital, and some of them cross paths. Some of them work at the hospital and work at the clinics, and they're bringing up issues that need to be resolved. But more importantly, we're focused on doing everything we can to improve our data towards the end of the year, and I would say that there's a bit of an excitement for that. That's at least from our doc's perspective. So there is some good news out there.
thank you.
Supervisor Canepa, I would just clarify that the $6 million would not come out of the general fund. Our assets are separate from the county, and it would come out of the clinic's cash. It's not included in the general fund.
So they have just over $20 million they'd either have to pay cash for, pay as you go, or they'd have to take some sort of debt on. But yeah, Chris is right, it would not come out of our books.
Thank you.
For the record, there was no public comment today.
Yeah, I noticed that, thank you. Yeah,
And I just had a question. Does increasing the volumes by having a clinic in Lodi, does that help with the overall costs of making budget?
Yes, well, there would obviously be new costs added to our cost pool. But I do believe that there are economies of scale with our purchasing and things, so that would, somewhat offset costs that are currently at our clinic and transfer a little bit to the Lodi site.
You know, also would have new fixed costs at that site, but we also have home office fixed costs that would be spread more broadly.
In particular, those. Yeah.
Thank you.
Okay, well, I just have one, go ahead. Counsel.
I have another meeting at 10:30. Also, we need to be mindful of what is agendized, and so we want to not just have a free-for-all. We want to make sure we're sticking to what's agendized.
Thank you. And I'm mindful of the time, but given the robust discussion and the topics we have, I wanted to at least let everybody get out what they had, and I certainly want to address our supervisor's question. I am going to wrap it up in 30 seconds. Before I do that, what I want to do is, all these discussion items that we're having now are very high-quality discussion items, okay? I want to comment and compliment the fact that we're actually at a point now where we can have these kind of talks and really hone in on what the issues are. I'm telling you, 10 years ago, the issues were splattered all over the place. You couldn't even get your arms around them. We have our arms around them. That's why you hear this heated debate and questions going back and forth. So to me, that's a good thing. We're in a place where we can move forward and continue to narrow down the issues. So I just want to compliment everybody on, it's actually a good place where we're at. So with that, I'm going to close the meeting out, adjourn it at 10:28, and we'll see you all next month.